at work, and we would run into each other at the proverbial water cooler, or perhaps talking across cubicles or wherever it might be in the office. We would have these informal conversations among colleagues that can really move the needle in some exciting ways. And trying to outsmart the PowerPoint dynamic, we can kind of really quickly zoom out on. Instead, set up this idea of a cafecito meaning small coffee. Greetings. My name is Eliana Ramirez. I'm the director of the Community Mental Health Equity Project. I'm thrilled to welcome you to a cafecito, which means small coffee, interview with colleagues Samantha Fusselman and Melissa Mollard from the Behavioral Health Concepts Incorporated. Welcome to both of you. So glad that you're here today.
Thank you for having us.
The Community Mental Health Equity Project, for anyone who is unfamiliar, we refer to ourselves as CMEP. We are funded through AB 74 as administered through the California Department of Healthcare Services, DHCS, to pursue two primary goals. The first is to collect information from the community that will lead into recommendations for revising the Cultural Competence Plan guidance. Cultural competence plans are written every 3 years by county behavioral health departments, oftentimes in coordination with local community-based organizations, to identify local behavioral health disparities and create plans to work towards increased health equity. In addition to collecting information from the field to make recommendations for revising the CCP guidance, we are also tasked to provide training and technical assistance to the field at the county level regarding culturally and linguistically appropriate services and data-driven services. For the purpose of both collecting information from the field as well as providing TA to the community, we have designed cafecitos, which are these short informal conversations among colleagues to share information that's related to cultural competence plans, class standards, the use of data as we address health disparities, and a variety of other topics that relate to cultural competence plans. So today, our colleagues Samantha and Melissa were gracious enough to join us to talk about their work, in particular regarding California's External Quality Review Organization and their work at BHC. So we would like to go ahead and get started. For folks who are unfamiliar with BHC and your work in the California External Quality Review Organization, I wonder if you would just give us an overview of the kind of work that you're doing, especially as it regards to the county level CCP implementation, please.
Sure, absolutely. Thank you very much, Eliana, for the opportunity to do so. I'll go ahead and share a little bit about the history of BHC and what we do as the California Mental Health and Drug Medi-Cal External Quality Review Organization, and then hand it over to Melissa to talk a little bit about the interface with the Cultural Competence Plan. So Behavioral Health Concepts, or we refer to ourselves as BHC, was founded in 1994 by our current president and CEO, Dr. William Holcomb. We're certified by the Centers for Medicare and Medicaid Services as a quality improvement organization-like entity. And since 2014, we have been the External Quality Review Organization, or EQRO, for Medicaid mental health plans in California. So the Centers for Medicare and Medicaid Services require an independent external quality review of all Medicaid managed care companies or Medicaid managed care plans. And in California, mental health plans and drug Medi-Cal organized delivery systems are two types of those managed care plans, referred to as prepaid inpatient health plans. So currently, BHC holds two contracts through the Department of Healthcare Services in California to conduct external quality reviews for all 56 mental health plans and 31 drug Medi-Cal organized delivery system plans. So there's 31 counties, no, 30 individual counties and one 7-county regional plan. So that makes combined 31 plans in California. So essentially, we're that third-party independent organization who reviews each and every behavioral health plan in California on an annual basis with a particular focus. We're charged with looking at access to care, timeliness of those services, and the quality of care that is provided to and delivered to Medicaid beneficiaries, or in California, Medi-Cal beneficiaries, and how the plan utilizes data and their information systems to really measure performance and understand their system, and how they use data to drive decision-making across the system and look at clinical and functional outcomes and such. So just to give you a little bit of a snapshot of how we do this, we have a 3-step process. We sort of have a pre-review process where we review extensive documentation shared with us from the county plans. And then we have the review process where we actually get to go on site, either physically or virtually in the last couple of years now, where we're able to really kind of validate what we've read and put to life what we've read by talking with people at all different levels of the organization. We're able to talk with people who receive services, people who provide services, line staff, supervisors, managers, community partners, county staff, folks who hold a dual role of both a recipient of service and a provider of service with lived experience. And it gives us an opportunity to really put to life what we've read about beforehand. And those key informant interviews are really a huge part of how we validate our findings as we evaluate the quality of care that's provided to the beneficiaries in each county. And in our review processes and the multiple sessions we conduct, we weave in questions that include discussion about cultural competence. We either have specific sessions to hear about cultural competence activities and strategies utilized by the plan, and we also include related questions in interviews and sessions that we conduct with various stakeholders throughout the process. And then the post-review process, we actually come back and talk with our larger team about what we heard, what we saw, address any additional questions we might have, and then we generate a report within a month or so after the review. And in that report, we really focus on those high-level themes that we identified throughout the course of the entire review and identify really significant strengths that are seen in the system, as well as some challenges and opportunities for improvement, because as we're looking through a continuous quality improvement lens, we're always looking for ways that we can continue to raise the bar and improve what we're doing. And then we also make very concrete recommendations with the goal to improve the quality of care that's being delivered within that system and that's attainable within the next 1-year period. And I think the last thing that I'll say before handing it over to Melissa is that it's really important for us that we recognize that the EQRO is a mandate. It's just part of doing business as a managed care plan in California. Drug Medi-Cal plans, mental health plans are kind of stuck with the concept of an EQRO. And we feel like we have the opportunity in partnership with the counties and with the state to make it a meaningful and a relevant process for the counties and their delivery systems and the beneficiaries that they serve, and to assist DHCS in monitoring all of that. And a big part of that is looking at culture and the many facets of culture and how that interplays with quality improvement. So I'm going to hand it over, Melissa. I know you had some things you were going to share about our performance measure data and how that relates to the CCP.
Let me unmute myself. Thank you, Samantha. Yeah, I wanted to kind of hone in on some of the data that we bring to the counties or the MHPs that help us have a starting point for conversations at various levels, including around cultural competence. Before we go out to the review, we actually read the county's cultural competence plan. And then we can look at the data that we generate and start to draw some connections, or at least develop some questions that we want to bring on site or virtually when we're conducting the interview or the focus groups and review sessions with the county. So for mental health, we use the Short Doyle Medi-Cal approved claims and inpatient consolidation data to produce approved claims summary reports, as well as some performance measure reports. So some of those measures that relate very specifically to cultural competence are things like looking at total number of beneficiaries served by race ethnicity. We look at penetration rates for a 3-year trend by race ethnicity, and other elements such as foster care. We compare those penetration rates and average cost per beneficiary to other like-sized counties as well as statewide. So we have not only how the MHP looked and did over a 3-year period, but also how they compared to like-sized counties and statewide. So those elements can often, then we can kind of connect the dots and look at, for example, how the penetration rate for the Latinx community has looked for that particular community or county. And we can then kind of crosswalk and look at their CCP and see, well, what are the strategies that this county has implemented to make inroads and to try to increase access for this particular race ethnicity group. So again, the data, that's one example of how the data kind of supports our review efforts as it relates to the CCP and helps us kind of generate some questions and incorporate both our data that we produce that's from the county. I mean, it's really their data, as well as the plan that they've developed to try to develop strategies to meet the needs. One other thing related to our use of data is that we look at proportionality. So we have a couple of methods where we look at the percentage of eligibles in a county by race ethnicity, and then the percentage of those clients actually served. So we're trying to get to we're trying to see maybe not a perfect proportionality, but we want to take a look to see, are there race ethnicity groups that are more likely to be served compared to their percentage of eligibles, and are there groups that are less likely to be served? And not surprisingly, white individuals are more likely to be served in many of the counties throughout the state, and the Latinx and Asian Pacific Islander populations are less likely to be served. So then we can look at the CCP and see what efforts are being taken by the county to try to increase access.
I am so grateful to the two of you being here. Oh my gosh, it's really exciting what you just shared. I have a million additional questions. So
you can ask.
No, this is so exciting. And I can only imagine our audience of county behavioral health department ethnic services managers, county behavioral health department directors, and local CBOs, community-based organizations, and other stakeholders who are also working on these issues. I can just imagine them feeling like, oh my gosh, we've just stumbled upon this incredible resource in so much of what you were just sharing. Samantha, when you first talked about how the EQRO is a requirement, but you're striving to make it meaningful, this is, I think, is going to resonate so strongly with people. In our listening sessions, and we've done several across the state at this point, also virtually, but with ethnic services managers, behavioral health directors, and CBOs, we are hearing a similar theme around wanting to make sure that the CCP is meaningful.
Yes.
It's not a checkbox kind of experience. And I really appreciate that strategy that you mentioned of going in and meeting with people directly to, as a check for what you're seeing in writing. That's a really bringing that context and to be able to see real people within a data set is, I think, such a powerful approach. And I'm thinking also, Melissa, about what you were just sharing regarding that you read the CCPs. Again, I imagine people's cheeks might be hurting from smiling so much. The thought that somebody else is reading these CCPs, because the ethnic services managers and the cultural competence committees, when they're fortunate enough to work with a group of others, in the development of the CCPs spend a lot of time.
Oh,
Oh
yeah.
my goodness, they really put a lot of work into these documents. So to know that somebody else is utilizing them, I'm sure can be just incredibly, not just affirming, but leading back to that idea of the CCP having impact rather than just a checkbox experience. And I'm wanting to kind of ask you a number of follow-up questions about what you've seen in the CCPs, but I'm going to be respectful of my invitation to you both that this be a somewhat brief conversation. And so if you don't mind, I might invite you back for another conversation
Sure.
to go further.
We'd love it. It's something that we're both very passionate about, I think, and not just us. I think that reflects the feelings of most of our colleagues at BHC. This is really important. Yeah, I'll just summarize it like that.
Absolutely. And the counties themselves. I mean, I think Samantha would agree that some of the most passionate discussions that we have in the counties are around culture and cultural competence and cultural responsiveness. So we really do recognize all the amazing work that counties are engaged in around this area. And just the other thing that Samantha and I were chatting about before this call around the CCP is that it isn't just a checklist, and it's also not only a values statement, which is important, but it's a plan. It's how are we going to across the system increase access, attend to the specific cultural needs of our different aspects of our community, and how we really, and then ideally, how are we going to evaluate that those strategies that we implement are effective?
And I'm biting my tongue to not chime in and continue that, because I know we do have some structured questions.
Yes.
Sorry, and I'll probably weave in some more of that, but I also really resonate with the intention and purpose of the project that you're working on. And I really appreciate the approach you're taking, because what we see across the counties is a real, genuine commitment to improving equitable access to care for everybody that is served, not just Medi-Cal beneficiaries, but for everybody that comes into a county system. And one of the huge obstacles that we hear about time and again are those infrastructure challenges of access to data and having the skills and the resources to understand and analyze the data. And it's so to be able to figure out a process or a structure for the plan to take care of that piece of it, so that the people doing the work can really focus on doing the work. It's just really exciting. So thank you again. We may have to cut some of that out.
No. And I'm happy for this to go wherever it feels natural for us to go in this conversation, and appreciate your willingness for me to invite you back again. The other piece that you mentioned, well, several of them, but one of them in particular, Melissa, when you were talking earlier about, and this is paraphrasing, but a growth mindset, this idea that if we're doing quality improvement, and if it's continuous, that we anticipate that as we collect new data, that we are going to course change a little bit. And that's actually a really incredible thing to happen. That is a really good sign. If we step back and just look at the cultural and linguistic appropriate services at a national level, that's embedded within the class standards. This idea that we want to do continuous and data analysis and data collection, and then change. We expect change. That is it's actually a good sign that we're doing what we should do, rather than, oh, we've been making mistakes. It's like always knowing that with diversity, equity, inclusion work, addressing health disparities, working towards health equity, there's always going to be something more that we can learn and do. And that is, I appreciate that kind of approach that you were just taking, and normalizing that it is hard for many people to access data and to know how to use data. And many people might know how to use it, but they are doing multiple jobs. I've heard
yeah.
from ethnic services managers in some counties who are also the MHSA coordinator, who are also doing 2 or 3 other positions. And that's just the reality of some counties' experiences. But then if we contextualize this within 2022 and the incredible impacts of the pandemic on staffing, and it becomes even more complex for people to find the time to devote to this work. So that you are talking about having reports, and it's incredible that you turn your reports over within a month of completing your data. I'm just again thinking people are going to be so excited to be able to look to your work as another source of really important information for them. And I wonder if you could talk a little bit about where you see the cultural competence plans fitting within quality improvement efforts across the state, please.
I think that's a great question. And before I go in to answer that, I want to just backtrack a moment. I did say getting our reports out there within a month. That's our goal and our target in the first step of it. The final report is completed within 3 months, but between 1 and 3 months. I just don't want to, misrepresent what we're able to do. We're certainly striving to do it faster. I think, Eliana, you just really did a nice job talking about linking sort of the class standards being a continuous quality improvement approach. It really is a matter of continually looking at and evaluating the work that's being done, and then shifting and course correcting along the way in pursuit of continually improving performance. And I think that's one of the really important distinctions between merely checking a box because it's a requirement versus striving to improve the underlying purpose and meaning of whatever the work is that you're doing. And so, at my core, I really believe that anytime you're looking at quality improvement or performance improvement issues, particularly within behavioral health, that's my area of expertise. It probably is true among other areas as well, but particularly with behavioral health. And so whether you're looking at improving access to care or timeliness or quality, that you absolutely have to consider the diverse needs of the local community, the individuals within the community, those who are experiencing the specialty mental health and substance use needs, and really expanding the concept of culture beyond the more traditional concepts of race and ethnicity or sexual orientation and gender identity, SOGI issues, or age, that looking at performance improvement within mental health, the importance of considering the impact of experiences related to criminal justice involvement or foster care beneficiaries. So the difference when you're looking at a transitional age youth population and perhaps developing a program or looking into potential barriers to access, is there a difference for those who have the cultural experience of having been in the foster care system versus a transition aged youth who may have similar behavioral health conditions, but different cultural experiences in that regard. And likewise, when we're talking about mental health and access to services, there's definitely a cultural consideration for people with severe and persistent mental illness, with specialty mental health needs, and their experiences versus those who have mild to moderate conditions for mental health and the experiences of accessing care. Also different between at times, or at least it's a cultural consideration, it's not a guarantee, but certainly a consideration, is mental health and substance use. There are different kinds of cultural considerations that need to be taken into account as well. So you mentioned having spoken with many of the ESMs or the ethnic services managers who wear multiple hats, and certainly the connection with MHSA and cultural competence in the ESM role, and also with the QI coordinator and quality improvement coordinator role. And oftentimes there being that interface between the quality improvement work plan goals and the cultural competence work plan goals and the working committees under each of those umbrellas, and how they really do link together. And I think, Melissa, you had some ideas about that too, about the effectiveness of using the CCP as that tool for some of that.
Yeah, just to piggyback off of that, I think that when it's one thing to have a CCP that's includes a lot of analysis of the unique needs of a county, and has gotten, stakeholder input and feedback from key informants or experts in the field to really identify what some of the challenges and unique opportunities are. But when that CCP also starts to be threaded through the quality improvement plan and starts to be used as a way for the counties to identify specific performance improvement projects, that's when you're really going to, I think, start to see ownership of the whole system for cultural competence activities, and where by having that kind of threading through other elements of quality improvement and other elements of kind of monitoring and tracking clients' access and timeliness and quality of services. That's, I think, where that CCP is going to be most effectively implemented, or most effectively kind of, what's the word I'm looking for? Like, have the most impact within a county. So it's not a standalone, it's really not meant to be a standalone strategy. It's meant to be a place where there's concerted effort and attention, and to memorialize what some of the issues and challenges are and what strategies have been identified, and then kind of taking those things and making sure that they're embedded throughout the system.
It's like you were in the listening sessions. My goodness, you are singing the tune that we are hearing over and over again from people. No, really, I mean, because they're saying, well, we've got a 3-year MHSA plan, and then we've got a 3-year CCP. And, in the best case scenario, they are informing one another. There are particular types of data that are collected on the MHSA side of the house, for example, around client satisfaction. Well, that's another important indicator for a CCP, and vice versa. But also, I think the piece that you just mentioned about the CCP as a plan showing up in other places, being woven through the system, that's where we start to see potential for transformational change versus transactional CCP, which is another piece that we're hearing people talk about. I affirm so wholeheartedly the intersectional approach also, Samantha, that you shared about thinking really, I think in a very deep way about identity, about culture, and about lived experiences, and how important that is. And we're hearing from a number of stakeholders, people who access behavioral health services, as well as family members and others from the community, who are talking about what does health mean to different communities? Might the actual definition of what health what we should be paying attention to, might it be different for different communities? Also, which behavioral health considerations are most prominent for certain communities? And when we use terms like Latinx, or we reference Asian ancestry and Pacific Islander communities, my goodness, there's so much rich diversity within these communities. Are we talking about language, or are we talking about generational status in the United States, or any number of additional? So the way that you have formed that initial entree into us thinking about culture beyond what historically has been considered, that I think also takes us from a checkbox to more contextualization, which is key. I'm also hearing from the ESMs this idea around where, if it's important to look at penetration data, but then also, what are the outcomes? How are the actual outcomes similar or different for different communities? And I think you started to talk a little bit about that as well. And I'm taking myself also back to our questions, which are kind of, this is my maybe not so graceful entry back in there, but one of the questions was, what themes have you seen in terms of areas of CCP strengths? And I think you've talked about this a little bit, but I wonder if you might pull that out a little bit further, since you've looked at so many of them.
Absolutely. one of the things that we've definitely seen, particularly, and we talk about this in our most recent annual reports that we produce each year, is that we've definitely seen an increase statewide in the implementation of strategies to address the needs of diverse communities. And so, in fact, in this last fiscal year, we found that every one of the mental health plans that we evaluated did indeed demonstrate significant effort at improving disparities. And some of the strategies that we've seen that were talked about during site reviews and that we've read about in the plans and meeting minutes and such are sort of the operationalization of the work that's come out of the CCP planning process, representing stakeholder feedback, including feedback from those who are receiving services, those with lived experience, and the focus groups, and looking at the research and literature and expert consultation. And a couple of those strategies that come to mind that counties have provided a lot of anecdotal observation to is the effectiveness of recruiting and retaining a bilingual and bicultural workforce, and having trainings on cultural competency, but around particular areas. And some of the areas that we heard a lot about in this last year that were perceived as being impactful were trainings around awareness, increasing staff's own awareness of their attitudes and beliefs about other cultures, knowledge and skill development. So providing education on the populations in the communities, help-seeking behaviors and what that might look like, the view of mental health within different communities, increasing staff's clinical and social skills when it comes to delivering services in a culturally, humble and appropriate manner. An example of that training that comes to mind is increased use of screenings for children that incorporates the assessment of ACEs, of the adverse childhood experiences. So I think that's one example or a couple of examples of what we've seen in terms of strengths for the CCP. And something else that I'll just mention, and I don't think we really have the time to go into the detail of it here, but the EQRO has been in California looking at mental health plans since about 2004-ish. I can't quite remember the exact year, but we were able to take a look, and we have done this. Melissa mentioned we do trend analysis over time for different metrics, but we've really seen improvement in the relative access for the Latinx population in terms of access to services. So comparing what the penetration rates were and the relative access for that population 10 years ago compared to what we see now, there's definitely been an improvement in that there's still room to go by all means. But I think that may indeed be a reflection of some of this really hard work with the counties and the CBOs that we've been talking about. And I think I'll stop there because I'll just keep talking. And Melissa, I think you had other stuff that you maybe were going to add, or I might have covered it all.
Yeah, well, I think those strategies are things that we've seen that I think have made a difference in access. But then also going back to your point, Eliana, about looking at outcomes and getting beyond just who are we getting in the door, but then starting to support counties to look at, how long did it take to get individuals in the door? And are there differences by race, ethnicity, for example? And then beyond that, they're in the door, but are there differences in terms of length of stay or successful transitions to a lower level of care? So really starting to move beyond access, which is absolutely important. But another thing you said that resonated for me, which I think also resonates with quality improvement and with the work that counties are doing, is the work isn't over. You don't reach a point where you're like, well, we've done that, we've completed that. You're continuously thinking about how to improve things and how can we look at this from a different angle to try to improve what we're doing. So I think starting to look at those kinds of timeliness and quality elements. And some counties are absolutely doing this. I do think there are some limitations with data and data sharing and interoperability that that continue to be challenges, but at least those questions are starting to be posed as something that needs to be looked at.
You know, and Eliana, you mentioned when we were talking about just sort of the categorization for penetration rates and API being a very broad category, and multiple considerations on cultural differences and linguistic differences. It reminds me of another sort of strategy that we've seen across many counties is looking at access to care or timeliness of services broken down by language preference, either by threshold language or beneficiary language needs. And so not just looking at, you know, how quickly overall are we able to get people in the door, but is there a difference between race and ethnicity or age groups? But also, is there a difference even further for people who are Spanish speaking versus English speaking? And if there's a gap, that also presents an opportunity for quality improvement efforts. And so that also ties back into that interrelatedness between quality and CCP.
Absolutely.
Whenever I leave the state, I am constantly telling people how proud I am to be of California and you from California. And you just shared another amazing data point here, which is that you're seeing increased implementation
Yes.
across the state. And I'm kind of like bursting at the seams with pride right now and wondering to what extent the ESMs in individual counties have had an opportunity to take that state level view and to see how this incredible hard work that they're doing is along in context with the work of other counties. That I think for so many of us who work in this field of addressing health disparities and working towards health equity, my goodness, it feels like we're kind of drinking out of fire hoses oftentimes. There's so much that needs to be addressed. And so I am, you know, and I'm ever the optimist, looking for these moments where we can really step back and feel a sense of hope, and it being data-driven hope. And I think what you just shared is such an incredible reflection of this legacy, that my understanding is that the CCPs that we have in place today are actually in place from 40 years worth of work. Advocates, behavioral health providers, administrators, starting back in the mid 80s to talk about how important it was to look at these issues. And I just really hope that those who are still in the game or who might be retired but have happened upon our cafecito can really take a moment to appreciate this, that there's this implementation that you're seeing across the state. What a powerful reflection of their work. I'm aware of our time here, and just wanting to think about kind of maybe we have space for one last question, if I might. Thank you. Okay, so what themes, if any, and you've talked about this a little bit, but what themes, if any, have you seen in the ways data is used or data are used to inform the CCPs, both in terms of effective uses of data and areas for growth in using data?
I can take a swing at this and Sam chime in.
Sounds good.
Well, I think that one of the positive areas that data is used is in kind of constructing what some of the gaps in access may be, or where some of the gaps in timeliness may be. So data, I think, is used to describe and articulate some of the problems that then that data can then be used to identify specific strategies to try to close some of those gaps or improve timeliness metrics, et cetera. I think some of the areas for growth are really around evaluating the effectiveness of the strategies. So the strategies will often be well articulated and evidence-based, and the plan links to the the QI evaluation and all of that. But I think where we're seeing some counties struggle is in really evaluating the effectiveness of that particular intervention or strategy to different data metrics. And some of that is just articulating the right outcome to look at, or being able to access the data, or to have the resources to do that kind of, data analysis. So it's a mixture of, I think, of factors that create some barriers. So, I think we try to do some technical assistance around that, but I think there's some opportunities for additional technical assistance that I'm wondering if Sam can speak to a little bit.
I think you're spot on. And, we did talk about how, 100% of the counties that we reviewed last year demonstrated meaningful efforts to address cultural concerns and CCP goals, for example. But just barely half were able to demonstrate any kind of results or provide outcomes related to that effort. And so I think that's really where this great opportunity comes in, is the opportunity is not so much in taking action and making improvements, but the opportunity is in capturing, measuring, reporting the efforts that are being made and looking at the efficacy of those efforts. And so that's part of what makes me very excited personally and professionally about the CMHEP project, is to be able to look at ways to help counties with that next step, and CBOs with that next step, so that they can begin to demonstrate the efficacy of that very hard committed work that's already in progress.
That was so exciting to think about as a potential second cafecito with you both. I wonder if that might be a really great place to go the next time that we come together. I again can just imagine people are putting a lot of hard work into these plans, and there's a really hard work into implementing. And I know as a researcher myself that there's nothing like that moment when you look at the data that's available, that's been collected, and said, oh, I wish that this other question had been asked, or I wish that we had asked it in a slightly different way. I'm realizing now that I see the data that it's not quite getting at what I know was out there. And so I think you're spot on, Samantha, in talking about that as a real opportunity for TA. I think so many of us, I myself am a social worker, and I was lucky enough to go as part of so, in our profession, focusing on evidence-based practices, focusing on measuring the impact of our work is really key. And so many of us are working in jobs where it either might have been a while since we had an opportunity to go through that specific kind of training, and we can kind of glass over our eyes when we start to talk about research, or frankly, we're doing so much work that there isn't the time that's needed in the beginning as we're setting up our surveys or establishing our listening sessions or whatever form of data collection it is. So I'm constantly telling people in the field, you have this incredible mind, incredible expertise locally. You know what's going on locally. If we can just bring in a little bit of TA on this other side to fine tune it a bit, then we're able to create an environment where everyone can see the great shine that's actually happening here. We don't want to miss that opportunity, because frankly, at the end of the day, it's also client service recipients who their own work on their own recovery. It's a matter of also being able to tell this incredible story of their experiences as well.
Absolutely. And when you look at, particularly in the last couple of years, and the tremendous amount of stress people are under, and the exhaustion and the burnout, and that's something we're hearing so much about, one of the added benefits to being able to have access to and report on this data is it can be very validating for the people who are doing the work that it's making a difference. And so it creates an opportunity to pause and reflect on all the good work that's being done, because so many of us are constantly looking ahead at what needs to be done next and what needs to be done next. And so there's that added benefit that comes with being able to look at the data as well.
Absolutely. Well, we would be delighted to come back and focus in on that question in a future Cafecito.
Yes, we would.
Thank you both so much. Thank you for the generosity of your sharing here, being willing to come back again, and just the really strengths-based and thoughtful and affirming way that you are approaching the work that you are doing with the counties. As just another colleague on the side over here, your work is making a difference. I am feeling all sorts of excitement that the people who can see this Cafecito will find it very useful as they go into their next iteration of CCPs. So thank you so much. We'll look forward to connecting at a future Cafecito.